So, hello everyone, and welcome back again to the Mycetoma Research Club. I am Samira Mohammed. I'm a research assistant at the Mycetoma Research Center, and I'm also the coordinator of the Mycetoma Research Club. And today actually will be the last session in 2024 until we meet back again next year. And we're having Dr. David from the UK who is joining us to give us a talk on the development of mycetoma activity and severity clinical scale. And Dr. David is a research assistant he's an honorary research fellow at Brighton and Sussex Medical School. And he spent, I think, 2 weeks in Sudan. He visited us at the Mycetoma Research Center and we had a wonderful time then. And Prof, it's over to you if you want to add anything.
Thank you very much, Samira. I would like to welcome David for this Mycetoma Research Club. This is a club, a forum, a meeting, a platform where we meet together, discuss important issues, we have discussions, and that is a very friendly atmosphere for exchange of knowledge and knowledge and sharing experience on this. And today we're going to talk about a new scale for clinical assessment of mycetoma patients. And David, we are very much pleased and honored to have you in this meeting. And we're looking forward for tell us more about this scale. I have to say this is the fairly scale, clinical scale to determine the severity of mycetoma. And again, it is not an easy scale to be developed, but it was a task. And I'm very glad that now task is finished and is going to be published soon in one of the highly reputable journals. David, thank you very much for accepting our invitation. I'm looking forward to be part of our group and to be an active member of the group in the future as well. Thank you very much. Thank you.
Well, thank you, Samira, and thank you, Professor Fahal, for inviting me to join this meeting. It's really great to be here with you all. So I will just make a start with the slides then. So as Professor Fahal said, this is I'm going to talk about a project that we've done to develop a clinical scale for assessing the severity and the activity of mycetoma. So we all know that mycetoma is one of the neglected tropical diseases, more common in Sudan, although cases occur throughout the tropical and subtropical regions. And the infection is characterized by grains in tissue, and there are many fungal organisms and bacteria which can cause this, and there's just an example here of an encapsulated mycetoma on the ankle, and in the tissue you can see the dark grains of Magurella mycetomatous. And we know that mycetoma can invade deeper structures, particularly bone, causing cavitating, destructive lesions. And these can be seen on X-ray and MRI. And this can be very difficult to treat and cause significant disability and a whole range of other problems for patients. So when we come to talk about how severe mycetoma is, what do we mean if we say a mycetoma, this mycetoma in this patient is very bad? What does that mean? How bad is bad? If we look at this mycetoma again, you might look at that and say that's not too severe. It's relatively small. There aren't many skin nodules. We can't really see any sinus tracts. So maybe that's not so bad. If we look at this mycetoma, well, you might say that that's a bit worse. It's affecting a larger area on the chest, shoulder. There are lots of skin nodules. You might say this one is quite bad. Equally, in this case here, there's a larger area involved. There's significant swelling of the leg. Again, lots of skin nodules. And you might also say this is quite bad compared to the first example. And then finally, there are very severe cases such as this one here, where you can have an involvement of internal organs, and clearly this is very severe, as severe a mycetoma as you could possibly come across. So we have a wide spectrum of severity, from small localized lesions through to larger, more extensive mycetomas, through to those which affect internal organs and ultimately may be fatal. But there's no measure, there's no way of objectively quantifying how severe the mycetoma is or how active the disease is. So with this in mind, we conducted this project, which was a Delphi study, to develop a clinical scoring system for mycetoma. So, so what we did was invited experts who were experienced in managing patients with mycetoma from around the world, and we ended up with 23 mycetoma experts, which formed our panel, and these were from 5 continents, so most from Africa, but also from North and South America, in Asia and Europe. And these were, the majority of the experts were very experienced, having 16 or 20 or more years of experience managing patients. Most of them were dermatologists, but there were also a significant amount that were academics or mycologists or other specialties, including infectious diseases, for example. And there was a 60-40% male-female split amongst the experts. So what we did in this Delphi study is, in the first round of the study, we sent a survey to all of the experts, and we asked them 4 questions. So the first question was to list all of the clinical features, so that's symptoms and physical signs, that could be used to measure mycetoma severity. Question 2 was to list all of the clinical features again that could be used at this time to measure disease activity. And the focus there was to try to come up with clinical features that you would expect to change to get better in response to treatment. Question 3 asked the experts to suggest how often they thought patients should be assessed clinically, so during treatment and after treatment has been completed. And finally, we asked a question, did they have any other comments on what we should include in the system or how it should be structured? And this was all done anonymously. So we sent these questions to each member of the expert panel, and the responses were collected anonymously. So at the end of round 1, we had a large list of clinical features, and they were divided into those for disease severity and for disease activity. And within these 2 groups, they were broken down into objective features, patient-reported measures, and investigations. So for disease severity, we had this list here of objective features, and then we had a few patient-reported measures such as pain or impact on ability to perform activities of daily living, and then we had some investigation results. And similarly for disease activity, we had some objective features, patient-reported features, and investigations. So this is how we organized the results that we received from round 1. What we then did in round 2 was we presented this list of features in this format, in this structure, back to the expert panel, and we asked them to score how much they agreed with each of these items. And what we defined as consensus was if there was 65% of the expert panel members agreeing that the item should be included. So from this list of features that we sent out, there was a very high level of agreement, but some of the features, there was not consensus. So for disease severity, there were these 3 items here, which there wasn't consensus, and they were removed. And these 2 features here, so increase in skin temperature and the use of direct microscopy, there wasn't consensus on those, so we removed those from the scoring system. Then in round 3, we presented this updated list back to the expert panel and asked them for any further comments. And there was generally a very high level of agreement at this stage with this list that you can see here. But there were a few further changes, and that included removing these items here on the number of skin nodules and the change in the number of skin nodules. So they were removed after round 3. And we actually added an item back in after round 3. So we thought that it was very important to include an item that assessed local inflammation, so raised temperature, sweating of the skin, and so we included this back within the disease activity scale. So this is the final scoring system that we were producing at the end of round 3. So we had 14 items for disease severity and 6 items for disease activity. Here, what this graph is showing is the level of agreement in the second round. So for down the left-hand side here, you have each of the items. So you've got the 14 items for disease severity at the top, and then the 6 items for disease activity at the bottom. And the colours are showing the level of agreement. So the dark green was strongly agree, and then the light green is would agree, through to the red, which was strongly disagree. So you can see for each of these items, there was a high level of agreement, sort of 80 to 90% in many cases, to include these items in the scale. And then coming back to the original question 3 that we asked, which was about how often patients should be followed up. There was again a very high level of consensus, and this is what was produced at the end. So the recommendation for follow-up during treatment was that patients should be assessed every 1 to 2 weeks in the first month, then every 2 to 4 weeks within the next 2 months, so months 2 and 3. And then from month 4 through to the end of treatment, it was every 1 to 3 months follow-up. And then after treatment, there was a division into a difference for eumycetoma and actinomycetoma. So in the first 2 years, it was recommended that it would be the same, so every 1 to 3 months in the first year, and then every 6 months in the second year. But for patients with eumycetoma, it was recommended that they have a further 3 years of follow-up with an appointment every 6 to 12 months due to the higher risk of recurrence with eumycetoma. So that's a brief summary of what we did in this project, the scoring system that we produced, and the recommended follow-up schedule. But this is really the beginning of this work, and the next steps will be to pilot the mycetoma activity and severity scale, the MAS, in mycetoma endemic areas in Sudan, in other places where there are high numbers of cases, to assess how easy it is to use, and if it's sort of feasible to do this in clinical practice, and then to go on and to assess how well it performs. So do the severity scores correlate with clinical outcomes of cure and other factors which are important to patients. And what we also want to do separately to including this in clinical practice is to include it in research studies. So future clinical trials and prospective studies can include this scoring system so that we can more accurately assess patients, follow them up during treatment, and assess their outcomes. So if anyone has any questions about this, I'm very happy to discuss now, or if anyone wants to email me, my email address is at the bottom of the slide there. I do have to say a very big thank you to Professor Fahal, who supported and supervised me throughout this project, as well as Professor Rod Hay and Professor Gail Davey from Brighton Sussex Medical School. And the funding for this this project was from the National Institute for Health and Care Research, the NIHR. Thank you very much for your attention.
Okay.
Thank
Yes, Samira.
you so much, Dr. David, for this nice talk. Now the floor is open for any questions and discussions. Yes, Prof.
Thank you very much, David, for this nice and elegant presentation on a very difficult topic to deal with. That is the clinical assessment of mycetoma patients. As you kindly said, that there is no standard method for assessing these patients or the severity of the disease. And again, this is reflect that the disease still is badly neglected around the globe. I have to say that every patient is a different story. The behavior of every patient is different from others. And this is one of the problems we're going to face when we're going to apply this scale in measuring the activity and the severity of patients. And again, that it shows that still we are far away from the basic knowledge about mycetoma, about the pathology of mycetoma, what is happening at the level of the tissues and the immune system, the genetics of the patient, and this. All these factors are important to shape the presentation of these patients. And again, to predict the outcome of the patient's treatment as well. So I think this will be a very good step for further assessment of these patients. But I still have to say that we are far, far away from the what is happening at the level of the tissues, behavior of the patients, the immune system of this patient, genetic background, and a lot of factors, the type of organisms, the site of the infection, and all these are factors predict the outcome of these patients. So this is the start of a good work have to be done in the future. Thank you very much.
Thank you, Professor Fahal.
Yes. Any comment?
Yeah,
Professor
can I have a comment, please, Professor Fahal?
Yes, Abdullah, yes.
Yeah, how are you? Thank you, Dr. David, for this presentation. It's a very, very important issue. And we have been facing this since a very long time. When I was in the Mycetoma Research Center, that the doctors coming to the clinic, following up the patients are changing all the time because they are coming for their doctoral trainings and new batch will come. And we were trying to make a paper file system at that time to make follow-up and scoring of the patient and the severity of the disease. But till now, everything will be very subjective, even for the criteria which has been agreed upon for this particular study. And I don't know why you did omit the laboratory testing, because the laboratory testing, I think, is not very subjective, although we don't have like a current lab test which is really precise and can monitor the severity of the disease. Thank you.
Yeah, I think the emphasis with this scoring system was to make it very much clinical. so that it could be used really in any healthcare setting. So it wouldn't rely on having access to lots of different diagnostic tests. But yeah, it will be challenging. As you say, there's such a wide variety of presentations, and it will be challenging to ensure that the scoring system is used consistently and reliably in different areas by different healthcare workers, and with mycetomas that present very differently. That will be part of the challenge in assessing the performance of the scoring system in the steps that are coming next.
I remember even with very expert staff in our clinic, we had a problem that when to decide to stop the treatment, for example, how to clinically assess the patient, and we come into consensus that we would like to stop treatment at this point of time. And sometimes we find that the patient come after a few months with a very massive recurrent. So even with a very expert and expert people in clinical presentation of mycetoma in particular region, still we have issue with how to predict the clinical cure.
Yeah, exactly. Now, thank you, Abdullah, for raising this important issue that including the diagnostic test as part of the assessment of this patient as well. Yeah, it is very difficult because you don't know what is happening inside the body, as I mentioned. Because some patients, they may come with this very small lesion, localized lesion for quite a long time, for 20, 30 years. Other patients, they may come with a very massive lesion for a very short duration. And we are not sure what is happening there at this. So again, the investigations may not be the end result of the story of this. So again, this really it is a difficult issue that, and when to stop the treatment. Again, this is a big issue in mycetoma patients. Even with our experience, the mycetoma center, sometimes we are facing this challenge. Shall we stop or shall not? 6 months or 3 months? Why not 3 months? Why not 6 months? Again, this is because there is no very clear test or marker that will tell you to stop the treatment at this point. And again, this is probably because some of these patients may go on with treatment for quite a long time. The drugs are very toxic, are very expensive, and not be available in many centers. And they may have another problems like diabetes, like whatever, and this and this and this. So really, it is a challenge. What to do for these patients? When to stop? Is this clinical assessment scale is useful or not? Is the laboratory test useful or not? So there is a lot of things has to be answered in dealing with mycetoma patients. At the Mycetoma Center, we have more than 12,000 patients. Still, we are having problems in reaching consensus on when to stop the treatment, what is the outcome, if the patient is having a proper treatment, what will be the outcome of that. So again, there is a lot of things to be answered. Thank you very much. Yeah, things are very much complicated with mycetoma. It is not very straightforward like other diseases like malaria or even malignancy, because you know the behavior of this. Thank you very much.
Dr. Ali, I see you have a raised hand. Feel free to unmute yourself and go ahead. Dr. Ali, you're muted. Unmute yourself.
Hello, everybody. Thank you very much, Professor Farhan and Dr. Samira. And thank you very much, Dr. David, for this nice presentation. And this new scale for this neglected tropical disease. I want to ask, and sorry for coming late, I came late, but I'm just asking about if any possibility of adding the nutritional status of a patient. I didn't hear if it is it in the scale or not, because I came late, as I said, and also the can some scales about response to treatment and follow-up for the improvement or stability or progression of the disease regarding treatment of this neglected disease, and also the psychosocial impact of a patient with a mycetoma, and maybe also regarding a treatment, as from our point of view as a pharmacist, the compliance of the patient with the treatment and also the treatment history. Can this be added, or it will add something or not for this scale? Thank you very much.
Yeah, thank you. Those are all really important points. There is an item in the scoring system for immunosuppression, and that would be open to any condition that would be felt to cause significant immunosuppression. So if the patient was significantly malnourished, that was felt to be relevant, then that would be detected, and that would be picked up by the scoring system. Regarding the disease activity, there is not an item in the scale specifically to pick up whether or not the patient has been compliant with treatment, or if they have had breaks in the treatment. Obviously, that is very important, a very important factor in the risk of relapse or recurrence. That's not something that the scale monitors specifically. Were there other items as well that you had that you asked about? I can't remember if there were some others that you mentioned.
Come again, sorry. The nutritional status of the patient.
Yes.
Right,
Yeah,
so,
so I think that the nutritional status would be picked up in as much as it might be a cause of general poor health and immunosuppression. So that could be picked up.
And also psychosocial impact of the disease.
Yes. Again, a very, very important aspect of the disease is its psychosocial impact. We did originally have more items in the scale. So many of the expert members suggested items relating to psychosocial impact, but they were subsequently removed as the emphasis of this scale was to assess the clinical impact of the disease, and it was felt that assessing psychosocial impact shouldn't be included in this scale, although there are other scoring systems that can be used to assess that, and it would be important for us to, when we assess the score, the clinical scoring system, to correlate that with those other scores. Scales that measure health-related quality of life and mental well-being, those scores could be correlated with the mass scores. But we did not have a measure of psychosocial impact within the mass.
May I have a comment, please?
For sure, Dr. Abdullah.
Yeah, I think we can also think about combining some laboratory tests, which should not be necessarily to be like specific for mycetoma. We do know that there is many laboratory tests which can be assessing the chronic infection in general. Like, for example, in bacterial infection, we use C-reactive protein, for example. Or sometimes we can use interleukin levels, like interleukin 6, which reflect the immune activation or response. And when it comes to fungal infection, we can, if it's Aspergillus infection, for example, we can use galactomannan. But if it's a general fungal infection, we can use the D-glycan level. I know that this type of test might not be available in every center, but at least we can have like some sort of laboratory test which assess the general response of the patient to the chronic infection, to be an added like laboratory test to predict the severity or the cure, the clinical cure, or the improvement at least of the disease.
Yeah, I think that's yeah.
I think this is
Sir,
sorry.
yes, Prof.
No, go on, please.
Thank you very much, Prof. May I add to Abdullah that maybe some also another laboratory or microbiological factors or can be added. I don't know. I'm thinking about some hematological or biochemical markers. Maybe Prof. Fahad or Abdullah can be more precise than me for this one, like inflammatory markers or the anemia or albumin, for example, can be added for this scale or not.
So, there is one item within the scale already, which is a very broad item, and that is any abnormal blood test or biochemistry which complicates the treatment. And we provide some more specific examples in the notes that go with the scale, but that would include anything, as you say, like anemia that might contraindicate an antibiotic such as dapsone, or any other abnormal liver or kidney function tests that might mean that the treatment might be contraindicated or require a lower dose. So again, the emphasis being with this scoring system, its clinical impact. That item was specifically worded so that any abnormal blood tests would be considered relevant if they had an impact on the treatment of the patient, rather than being used as markers of activity. So things like CRP, for example, that could be useful, but that hasn't specifically been included within the scale.
Professor Fahad, I see you have a raised hand.
Yeah. Thank you very much. I think really we need to include some laboratory tests in assessing the activity and the severity of mycetoma. But the problem, which test to be included in this? At the mycetoma center, we saw a lot of patients with mycetoma. We do a lot of testing, the hematology, renal function, adrenal function. We do a lot of tests on the on patient with amikacin sulfate, looking into the hearing function, renal function. But again, there was not very shouting result from this.
Yeah, maybe Prof, you should go for something like immune profile, like cytokines profile, because this is really correlate with the severity of the disease and the severity of the infection. And if you like omit the presence of other maybe comorbidity of other infectious diseases in the region, you can predict that, for example, this is the immune status right now of this patient. And we have many work have been done in the pathology of the mycetoma. We understand the type of cytokines produced during the infection. We know that the type of the immune response in mycetoma in general. So we can use this sort of test which predict the quality of the patient. For example, in HIV/AIDS patient, we use CD4 count just to predict the recovery of the patient. But we can't use CD4 count here, but we can at least use, for example, the cytokines profiling, like, for example, the interferon gamma, tumor necrosis factor, which goes usually with the immune system regulation. So we understand that what type of infection, what type of immune response is currently happening in the patient.
Yeah.
I think that's really important. So, sorry, I don't know if anyone else had their hand up. The only other comments I was going to make is that in the future, it might be that the scoring system is adapted, or there are other items that could be added, depending on what is available in different areas. So there needs to be a simple version of the scale that could be used anywhere in the world or in the most basic settings. But then for settings where there are access to more tests, then perhaps they can be factored in also. Yeah, so thank you for raising that point.
Professor Fahal, I see you have a raised hand.
Yeah. During our clinical trial that included 104 patients with mycetoma patients, we looked into the immune profile of these patients. Generally, there is no change in the immune profile over time with treatment of these patients. And even at 0 level, again, the immune profile of this patient was within normal. So there was no shouting result showing that there is abnormality in the immune responses of these patients during this treatment trial at this site. So again, that makes things very difficult. What type of test you have to do it? What type of immune profile test you would like to look for in these patients at this site?
I
So
think,
again,
sorry, Prof, but for bacterial mycetoma, it's clear it's a bacterial infection, and generally we can use the general markers for bacterial infection like C-reactive protein, very simple test which can be available everywhere. But for fungal infection, to have one marker to predict the severity and improvement in fungal infection, we have no other option in case that the cause of the mycetoma is from the ascomycetes, which contain the which contain the glycan in the cell wall. This is always reflected in the D-glycan level in the serum. So if you can add this D-glycan level in the serum, this will include all the mycetoma causes, which we know now, because they are all coming from the ascomycetes. And definitely they are contributing to the increased level of glycan level in the serum.
It was tested. It was tested in this patient with the patient at this clinical trial. We tested this test, and again it was not very significant.
Okay.
Over time at this site, and it was very unspecific test, and it got no improvement with the improvement of the patients even after surgery. There is not a lot of change. There is a drop a bit, but that was not significant. A drop in this. So again, this test was not very. I think this is one of the standard patients in to assess the fungal infection in patients. And again, that test was not very useful.
Yeah, maybe this is more applicable, Prof, in invasive fungal infection, not in chronic infection, maybe. Because in case of aspergillosis and other invasive fungal infection, this is very useful test.
Yes. Okay, that may be, yes. That may be because it's a longest standing infection, a low-grade infection, not severe, not invasive. And you can have a paper published, Abdullah, on this. You can see it, please. Again, not very much specific test for this.
Definitely,
So have to look for other tests, Abdullah.
Sure.
Dr. David, I see that there are some questions in the chat. One question is asking, is the pain score available, and could it be used by the clinicians for the diagnosis of mycetoma?
Yes, the pain score is one of the, it's an item on the disease severity scale, and it's a 0 to 10 visual analog scale. So that's one of the patient-reported measures under disease severity. And then related to that, there is an item in the disease activity scale, which is if there is a change, so an improvement versus a worsening or stability of the pain. So it's within both severity and activity parts of the scale.
And someone had some connection issues, so they're asking that, is the site of infection included in the scale?
Yes, the anatomical site of the infection is included. So, for example, head and neck mycetomas score more highly for severity compared with other areas of the body.
Okay.
Also, the size of the mycetoma and whether there's any internal organ involvement are included.
The question from our colleague Lubna, she's asking that, is the scale included in the co-infection and mixed infections as well as resistant cases?
No, that there is no that the scoring system is based on clinical assessment of mycetoma, whether it's eumycetoma or actinomycetoma, and doesn't specifically take into account sort of co-infection in terms of the scoring.
Right, thank you so much for this. Dr. Ali, you have a raised hand.
Thank you very much for this opportunity again. And maybe this scale is clinical. I'm just asking, or I'm just thinking about adding some questions or some skills about the emotional distress, maybe due to disability regarding patient going to surgery or something like that. Also, maybe adding some question regarding the quality of life. Can we add this, Dr. David? Thank you.
Yes. So so they were definitely recognised as being very important aspects of the condition. So emotional well-being and quality of life. And as I said, we did originally have an item within the scale to assess those, but it was later removed because the emphasis of this score was based on clinical features, clinical assessment, and not those other aspects. It was removed. It was also felt that it would be quite difficult to assess those factors and what might be emotionally upsetting for one patient is very different for another patient. So there were some issues around it being a difficult concept to measure, but also not being a clinical part of a clinical assessment.
Yes, Prof, go ahead.
Yeah, I think it is, and as I mentioned, it is a complicated disease, not an easy disease to diagnose and to follow and to have a clear picture about what's happening at the end of the day with these patients. So definitely we need to have another scale for the psychosocial effect of the disease. We need another scale for the stigma. We need to have a lab scale. So there's a lot of scales to be developed in the future, and hopefully in the future we're going to combine all these scales in one big scale for assessing the management of mycetoma patients. But I think this is a very good start to start with the clinical aspect, and then eventually we're going to add more and more items in this scale to be more comprehensive for the management. But still, there is a lot of confounding factors: the immune responses, the genetic background, the treatment outcome, the drug sensitivities. There's a lot of confounding factors that can affect the outcome of these patients. Thank you.
Thank you, Professor Pahal.
Yeah.
Well, Dr. David, Dr. Abdullah has raised something in the chat talking about the persistence of pathogen genomes. So I was asking, for example, in tuberculosis, there is the presence or absence of the Mycobacterium tuberculosis in DNA in the sputum. So what about mycetoma? Is there is DNA, can DNA be detectable in clinical samples?
It is detectable or can be detectable, and there are tests available, not widely used, but available more as research level tests to detect molecular tests to detect genetic material. I don't know if there is any sort of literature or understanding of how long that persists, or how that might relate to disease activity. That I'm not sure. So I hope that answers the question.
Limia, any comment about this?
Good evening. Thank you very much, Dr. David. No, actually, it was very interesting. Your talk was very interesting, and the comments, because I was also thinking like what Professor Fahan, Dr. Abdullah, and Dr. Ali have said, that I think this is just the beginning. And as you go on, it will pave the way for adding more, for example, laboratory tests, even histopathology, because I think the tissue reaction can give you a clue at the end regarding the management and so on. So I think maybe, like Professor Fahad said, this is the start. And from what you have emphasized, that this is just a clinical scale. And I'm sure this will even pave the way for other neglected tropical diseases. So thank you very much. I really enjoyed the talk and the discussion.
Yeah, thank you. And yeah, I do 100% agree. This is, as you said, this is the scoring system that's been produced specifically for the clinical aspects of the disease. But absolutely, the immunological, histopathological, the other aspects are very important, and they almost do need their own systematic way of assessing or categorizing or assessing severity, and linking that with the clinical scale, so that we improve our understanding of which factors are important on histology and clinically.
Yes.
And it is just the beginning. Yes, you're absolutely right.
Thank you.
Limia, I think we should look into a tissue marker in the histopathological examination that can tell us the stability of the mycetoma. Because as you know that we have a lot of studies done on the host tissue reaction and correlation with the clinical presentation, and that was none. So I think we should be on the look to find something at the level of the tissues.
Yes.
That may indicate that the severity of and the outcome of this. And nowadays, with the use of AI, hopefully people may come with some tests that will help us in predicting the outcome, as well as to determine properly the severity and activity of this problem.
Absolutely, yes.
So let us look and see what can we do for this.
Okay, come on.
Okay. It is very clear that there is a lot of work to be done, especially our young colleagues. Let us think together. Let us come with more ideas, more projects, and then you can do the work. to come with something which will be useful for the management of these mycetoma patients.
I totally agree with you, Prof. Fahal, and we have to look actually for a tissue marker just to make the scaling much more precise. And Dr. David, I think this is a really great work. And as the Prof said, that there will be a lot of work to be done. And I see that there are no more questions in the chat, and there are no raised hands.
Okay.
Prof, would you like to add something?
Once again, I would like to express my sincere thanks and gratitude to David for this nice presentation and for the good work he did. And I think this will be a very good start to validate this skill and to look into other tests that will tell us more about the mycetoma pathogenesis and how can we manage these patients. Thank you very much.
Well, thank you, Professor Fahal, and thank you everyone for the good discussion today. It's been very, very useful.
Okay, thank you very much. Have a nice time. Have a good Christmas and New Year.
Yes, you too.
Thank you. Thank you very
Thank
much.
you all. Thank you
Bye.
so much.
Okay.
Bye.
Bye.
Thank you very much.
Thank
Bye.
you.
Again. On
Bye.
7th of July. Bye.